Thanks for allowing me to present today. So I'm going to be talking about non-inferiority trials. So I'll start out with a brief outline of the types of clinical trials we come across, give a brief overview of non-inferiority trials, and then talk a little bit about the PROTECT AF trial, and then we'll conclude with some takeaways. All right, so the clinical trials that we normally come across can be divided into three types: superiority, equivalence, and non-inferiority trials. So superiority trials are really what we come across most often. And the way that these trials are all set up are slightly different from each other, very nuanced differences. So the superiority trial really looks at and aims to prove that a particular intervention is superior or more efficacious than a control. And this control could either be a placebo or a standard of care. In an equivalence trial, you want to prove that the intervention has a similar efficacy to the control. And most often this control is a standard of care. And then a non-inferiority trial, although it seems intuitively that it should be similar to an equivalence trial, is slightly different in the sense that you want to prove that the intervention is no worse than the control. So the way that any trial is set up, it revolves around two hypotheses. So there's a null hypothesis and an alternate hypothesis. So the way that this works is you take your aim and then you frame your alternate hypothesis according to the aim. And then your null hypothesis would then be the converse of your alternate hypothesis. Your entire goal of this entire process would be that with statistical analyses, you would be rejecting the null hypothesis. So you would be left with no option but to accept the alternate hypothesis. Let me make this a little bit clear with an example. So let's say that you're conducting a superiority trial. Like we said, the aim would be to prove that the intervention is more effective than the control, right? So that's how you would frame your alternate hypothesis. That's the H1. So you would say that the alternate hypothesis is that the intervention is more effective than the control. So your null hypothesis then would be the converse, where you would frame it as the intervention is not more effective than control. Okay. So say you conduct a statistical analysis, you gather all the data, you run the analyses, you've decided that your p-value of significance is going to be 0.05, and you achieve a statistically significant result. So at that point, you would reject your null hypothesis and accept the alternate hypothesis and say that the intervention is more effective than the control. In other words, you would say that the intervention is superior to the control. Say, for instance, you got a p-value of 0.1, and that is not statistically significant. You're unable to reject your null hypothesis. What would be the conclusion at this point? Does anyone have any thoughts? What would you conclude if you're not able to reject the null hypothesis?
Does anyone want to take a guess at it on the chat or unmute yourselves?
In the interest of time, I'm just going to go ahead and say that you're going to say that it's not superior. So if you're unable to reject the null hypothesis, you are unable to say anything else but the fact that it's not superior. Coming to an equivalence trial. So similarly, you want to prove that the intervention is as good as the control, right? So does anyone want to take a shot at what the alternate hypothesis would be in this case?
So Suren, if you reject, like if your null hypothesis is like that your intervention is the same as a control, if you can't prove that, what does your alternate hypothesis, like what would it be?
My H0, it would be the intervention is not equivalent to the control, and each one is like equivalent to the control.
Yeah, so and when you're framing this, you want to be a little bit more specific. So you want to say, so the alternate hypothesis would be that the intervention is not worse or better than the control by a pre-specified margin that you're going to call delta. And your null hypothesis then would be that your intervention is either worse or better than the control by this delta. In case of a non-inferior, and say suppose you're able to reject the null hypothesis, you would say that the intervention is equivalent to the control. And if you're unable to reject the null hypothesis, your result would be that it's not equivalent. You would not be able to say it's superior, inferior, anything other than it's not equivalent. Coming to a non-inferiority study, your goal is to prove that the intervention is not worse than the control. So your alternate hypothesis would be that the intervention is not worse than the control by a pre-specified margin. And this is very important because you need to specify by what amount you're saying it's not worse than the control. And then your null hypothesis would be that the intervention is worse than the control by greater than that delta. So if you're able to reject the null hypothesis, you're going to say that the intervention is non-inferior. But if you're unable to reject the null hypothesis, your conclusion will be that it's not non-inferior. So it can get a little convoluted, but just stay with me and hopefully things will become clearer. So does anyone want to take a shot at, why are non-inferiority trials conducted? I mean, you might as well just conduct a superiority trial, right? So why are so many non-inferiority trials conducted?
Maybe to have more options of treatments for the same disease. I mean, like two treatment or two intervention would be the same or at least not inferior to the first line therapy. If the first line therapy is not available or not tolerated or there is contraindication for it.
Absolutely.
If the
Any
only
other thoughts?
you have is like very expensive, that might be a good reason to do a non-inferiority trial, and you can say that a much cheaper medication is just as good or not worse.
Exactly. So a non-inferiority trial in comparison to either a superiority or an equivalence trial requires a low sample size because the difference in the effect is lower than in a superiority or an equivalence trial. So these trials end up being low cost and more convenient. And like Noor said, if you have a standard of care, you're not going to compare this new medication to a placebo because that's unethical. So just proving that the new treatment is non-inferior to the standard of care is sufficient. And then the third thing is the new treatment may not be worse than the current treatment in terms of its efficacy, but it may just be better in terms of other aspects like safety or ease of administration, cost, and other things. So a non-inferiority trial is more applicable in these cases. Okay. So one of the key components of a non-inferiority clinical trial is the non-inferiority margin or the delta. So this is a pre-specified difference above which the intervention is not worse than the control. Let me explain this with an example. So let's say there's a car in the market, costs $50,000, and it's the gold standard car. It's the safest thing available. All new models are compared against this car. Now there's a new car that comes into the market. It's $10,000 cheaper, and it's 1% less safe. And then say there's another car that comes into the market, $20,000 cheaper, but 5% less safe. So somebody like me that's risk averse, I'm gonna be like, oh, anything more than 0.05% less safe is unacceptable to me. So that's where I'm drawing the line. That's my risk margin. So that is really my non-inferiority margin. So I'm gonna be like, oh, 1% less safe, that's way too much for me. Anything greater than 0.05, I can't do. So I'm gonna pay the $50,000, I'm gonna take the gold standard car. Someone else might be like 5% less safe is totally fine. I'm gonna save the money and pay $20,000 less. I'm gonna get the third car. So for that person, they're drawing the line at say 5% or more than 5%. So that is that person's non-inferiority margin, right? So it's really the risk that you're willing to accept in comparison for the new treatment in comparison to the control that you're pitting it against. So as you can tell, with this car example, again, it was so variable from person to person. So similarly, when it comes to trials, it's really left to the people who are designing the trial to define what amount of risk or what margin they think is acceptable in terms of worse outcomes. And unfortunately, so there are a lot of guidelines around specifying these margins, but unfortunately, there is a lot of variation if you look at clinical trials and look at the variation in the non-inferiority margin. It can go anywhere from like 1.1, 1.2, all the way up to 10. So there's a crazy amount of variation. And unfortunately, a lot of trials also don't really explain how this non-inferiority margin was chosen. But this is really a key aspect to understanding a non-inferiority trial. So let's spend a little bit of time using, trying to understand this forest plot, because this is another key component of a non-inferiority trial. So for the time being, just forget that there is that line on the right side that says margin 1.2, just forget about it. So we're gonna focus on everything else on that graph. So basically the vertical line at 1 says that the relative risk is 1, which means the risk of adverse events in the treatment group compared to the control group is 1, which means there is no difference. If the relative risk is less than 1, it just means that the treatment is better. If the relative risk is greater than 1, it means that the control is better. Okay. So let's start with the first plot right here. I'm not sure if you can see my cursor. So the first plot here, you see that the effect estimate is 0.9 and the confidence intervals are both below 1. So nothing crosses the point of reference that is 1. So you will say that the treatment is better than the control. Okay, or in other words, this is really how a superiority trial is depicted. So you would say that the treatment is superior to the control. And you look at the second graph, you see that although the point estimate is greater than 1, the confidence intervals cross 1. Therefore, you cannot really say whether the treatment or the control is better, okay? So this is inconclusive in terms of the superiority aspect. But if you look at the third graph here, the point estimate and the confidence intervals are all above 1. So you can conclude that the control is better than the treatment, or that the treatment is inferior to the control. I hope people are following along with this, because things are just going to get a little bit more complicated. So now let's throw in that margin. Let's focus our attention on margin line. So the margin is the non-inferiority margin, and that's where 1.2 is the margin that the authors of this study have chosen. So they are okay with a relative risk of 1.2 or less to say that the treatment is non-inferior to the control. So similar to how we had a point of reference of 1 earlier, we're going to use the point of reference of 1.2 to define non-inferiority. So let's take the first graph again, right here. So you see the point estimate, it is less than 1.2. And you look at the confidence intervals, they're all less than 1.2. So from a non-inferiority aspect, you would conclude that this study is non-inferior. So overall, you would say that this study is both non-inferior and superior. It gets a little confusing, but you have to keep in mind that the point of reference for the superiority is 1, and for the non-inferiority is 1.2. Does anyone want to take a shot at the next graph, this one? In terms of the non-inferiority, what would it be?
Not inferior.
Exactly.
But not superior because of the 1.
Exactly, correct. So this will be a non-inferior study. What about the third one?
Also non-inferior.
Okay. And what else?
Not superior.
Sorry?
Non-inferior and non-superior, I guess.
Okay, so yes. So you would say that from a non-inferiority aspect, this is less than 0.1.2. So you're absolutely right. This is not going to be non-inferior. But from a superiority standpoint, the control is better than the treatment, right? So then this would be both non-inferior and inferior. It's a little counterintuitive, but you always have to keep in mind what the reference point is. Okay, let's go with the fourth one. Any takers?
So Frida, do you want to take it? Oh, Nora, I see you unmuted yourself.
I don't know, go ahead.
Okay, so Frida is writing in the chat.
Frida has it, yeah.
Yeah, so she said not non-inferior, non-superior.
Exactly, so this would actually be inconclusive. Okay, and the last one, anybody?
Inferior, but in the control is superior than treatment.
I'm sorry, I didn't get the last part.
So it's inferior.
Correct.
And control is superior compared to the treatment.
So from a non-inferiority aspect, the confidence intervals cross 1.2. So then it'd be not non-inferior. So it would be both inferior and not non-inferior.
Teresa has it in the chat.
Yeah, great. Awesome. Okay, so I think we're at a good point to switch gears now and talk about the PROTECT AF trial and apply all this knowledge to this trial. All right, so the PROTECT AF trial was published in Lancet in 2009. And at that time, warfarin was the mainstay of anticoagulation in patients with atrial fibrillation. But many studies had found that only 50% of eligible patients were found to be appropriately treated with the warfarin. So this study examined the potential non-inferiority of a Watchman device implantation, which is a left atrial appendage closure device, against chronic warfarin therapy in patients with non-valvular AF. So this was a study that included patients over the age of 18 years that had paroxysmal persistent or permanent non-valvular AF. And they used a CHADS-2 score of greater than or equal to 1. So they didn't have the CHADS-VAS score back then, so they used the CHADS-2 score of 1 or greater than 1 indicated a moderate risk at that time. And they excluded any patients that had contraindications for warfarin use, aspirin Plavix use, or that they needed to be on warfarin for an indication other than atrial fibrillation. They also excluded any patients that had contraindications to the Watchman device implantation. So this was a multi-center, open label, randomized controlled trial. Obviously, it was not blinded because this was a procedural trial. It was conducted across 59 centers in the US and Europe, and enrollment was between 2005 and 2008. So the intervention was a 2-to-1 randomization to Watchman and warfarin arms. In patients that received the Watchman implantation, they were started on warfarin immediately post-procedure, and they received a transesophageal echo at day 45, and then 6 months and 12 months. And they were assessed for left atrial appendage closure or insignificant residual peri-device flow. And once this was achieved, they were switched from the warfarin to Plavix and aspirin till 6 months post-intervention. And then thereafter, they remained on aspirin for the rest of their lives. In the warfarin arm, all the patients were started on warfarin with a goal INR of 2 to 3. And this was monitored every 2 weeks for 6 months and then every month subsequently. The mean follow-up time was 18 months. The authors assessed for both efficacy and safety endpoints. So the primary composite endpoint for efficacy was a combination of stroke, cardiovascular or unexplained death, and systemic embolism. And then the endpoint for safety included a combination of major bleeding that could be GI, intracranial, or procedure-related complications such as a large pericardial effusion or device embolization, things of that sort. So the statistical analysis was conducted with an intention to treat analysis. Cox proportional hazard models were generated, and Kaplan-Meier curves were also generated. So like I said, the non-inferiority margin is the key aspect, right? So the authors mentioned that they used a twofold non-inferiority margin. And unfortunately, there was really no other explanation of how they came to this conclusion or this decision to use a twofold non-inferiority margin. What does a twofold non-inferiority margin mean? Let's go back to this graph. So here, the authors of this other paper used a margin of 1.2. Now, a twofold non-inferiority margin puts this non-inferiority margin line way back here at 2, which means for this trial, anything less than a relative risk of 2 was acceptable as a non-inferiority. So you could have adverse events in the treatment group in comparison to the control group, all the way to the extent of, double the rate of what was going on in the control group. And that was accepted as a non-inferior intervention. Does anyone have any, first thoughts or any comments on that?
So based on what they chose this, my cutoff for the non-inferiority margin?
That is an enigma. I looked into the paper, I looked everywhere. Unfortunately, this is a thing with non-inferiority trials. Not every paper mentions what they used to choose and the non-inferiority margin. So we really don't know what went into the thought process.
Sani thinks that it sounds a little bit lenient.
Absolutely. I think it is a very, very liberal margin. If you're okay with adverse events or a relative risk ratio of all the way up to 2, it's definitely not conservative. Okay. So the authors also mentioned that they used a one-sided cutoff of at least 97.5% for non-inferiority. And all that this means is once they calculate the probability of non-inferiority using statistical analyses that we don't need to go into details about, if the probability was greater than 97.5%, that demonstrated non-inferiority. And this will become just a little bit clearer when we discuss the results. All right, so in total, there were about 5,000 patients that were screened, of which 707 were randomized. So 463 were assigned to the Watchman device arm, and 244 were assigned to the warfarin control group. So of the 463, this is really interesting. So 449 underwent an attempted implantation of the device. But among 41 patients, they were unable to implant the device. So only 408 received the implant. So of 463 in the Watchman arm, only 408 actually got the device. And then in the warfarin arm, 3 patients were never started on warfarin. So 241 actually received the warfarin. But it's interesting to see that in the intention to treat, of course, 463 are included in the intention to treat in the warfarin arm and, Watchman arm, and then 244 included in the warfarin arm. Okay, so these are the baseline patient characteristics. I'll just give a minute for everyone to go over this. And I would love to hear any thoughts that might jump out in terms of differences in characteristics.
Just starting with the first, I would just say not a very diverse group of individuals in terms of race, ethnicity.
Absolutely.
And even, I guess, gender as well. But the age, I guess you could give them one thing. Maybe the only thing that I see that may be similar, but otherwise, like the diversity is just not there in terms of gender and race.
Yeah. And then any thoughts on kind of the distribution of comorbid conditions, risk factors?
And does it seem reasonable for the question that they're answering or trying to ask?
So it seems like maybe the control group is a little bit sicker than the intervention group. So if you look at the rates of heart failure and hypertension, diabetes, previous ischemic strokes, they all seem to be just a little bit higher in the control group. Unfortunately, we don't have a p-value for the difference between these characteristics. So we really cannot tell if it's statistically significant, but that's something to keep a note of. And what would be the implications of having a sicker control group in terms of your outcomes?
Could make the intervention look more effective.
Absolutely.
Or safer even.
Yeah, exactly. Right. So if your control group that you're comparing against is sicker and they have higher rates of adverse events, your intervention is going to look more easily non-inferior, right?
And then you also are looking at, like, you know, what Sandy said about it's already being very lenient. So it's kind of like already you're kind of moving a certain way.
Yeah. All right. So coming to the results. So like I said, 88% of the patients that were randomized to the device implantation actually received the device. And at 45 days, only 349 patients had successful closure and were weaned off of the warfarin. So what this means is the rest of the 59 patients that received the device continue to be on warfarin for at least another 6 months, right? So after 349, another 6 patients met criteria at 6 months, so they stopped the warfarin. But then the rest of the patients, there's another 30 patients that stayed on the warfarin for a whole year. Now, coming to the warfarin arm, the therapeutic range was found to be, the patients were found to be in therapeutic range for only 66% of the time. Any thoughts, anything about these two results preliminary? Like what would you be concerned about with these numbers? That, you know, 59 patients of the 408 continue to be on warfarin for at least 6 months.
You wouldn't be able to tell if the improvement was secondary to warfarin or secondary to the intervention. Right. Those patients.
So, so basically, you know, these patients, the 59 patients are kind of, there's a crossover, right? So, so you really, you know, would be able to tell. And then the warfarin arm, apparently the authors reported that, you know, 50 to 70% was kind of an acceptable therapeutic range per prior studies, but again, there are questions about that, so. All right.
And that definitely makes it harder to see the difference between the two groups, but it's also more of a realistic scenario. Like, this is what happens in real life.
Absolutely. And I think that is why it's important to do both an intention to treat and a per protocol analysis, especially for a study like this, where you're trying to say that something is non-inferior.
Yeah, great point, Frida, because that's what I was looking at myself when I was looking at the numbers. A great point. And great answer as well, Niru.
All right, so this is the these are the results that that were finally published. So let's take a look. So this is the first kind of big row here is the intention to treat analysis. So looking at the primary efficacy overall, you can see that the observed rate is 3 per 100 patient years in the intervention group. And 4.9 in the control group. So it seems like the primary efficacy endpoint is better in the intervention group. So keep in mind that these numbers measure the number of adverse events in patient years. So So it was lower in the intervention group. And you see here that the non-inferiority probability was greater than 99.9%. Our cutoff was 97.5%. So the authors concluded that the intervention was proved to be non-inferior to the control group in terms of the primary efficacy endpoint. But remember that the primary efficacy endpoint was a composite endpoint, right? So it consisted of ischemic stroke, hemorrhagic stroke, cardiovascular or unexplained death, and systemic embolism. So if we look at ischemic stroke, in the intervention group, the rate was 2.2 per 100 person years, but it was only 1.6 in the control group. So this rate was significantly higher. And if you look at the posterior probability of non-inferiority, it was only 71.8%. Any thoughts on this? Like, would you be, if the authors told you that the intervention was non-inferior to the control group, would you be happy with that? Or do you have any other concerns? Do you feel like, oh, you don't really agree with the results? Or if you do, you agree, that's fine too. So whatever.
So I think the issue here is what you're saying is like, would you be okay just like lumping all these conditions together to like get the message for like non-inferiority versus like doing it isolated from like ischemic stroke, which is what you would normally be considering for atrial fibrillation and anticoagulation, basically, right?
Yeah, I would go with the separated endpoints rather than the total. Also, maybe it might be based on like how high the risk of a stroke in in each patient as well. So I wouldn't take the total.
You wouldn't take the total. That makes sense. Yeah. Anyone who would go for the total and be okay with the results, and why? Okay, we can move on to the primary safety endpoint. So here, when you look at the primary safety endpoint, you see that it's higher in the intervention group as opposed to the control group. And it's significantly higher. It's 7.4 versus 4.4. Okay, and then the authors then also looked at the successfully treated population. So the way they defined the successfully treated population was for the Watchman group, they said that anyone that successfully received the implantation of the device and were able to be taken off of warfarin were included. And then for the warfarin group, anyone that was started on warfarin was included, irrespective of the amount of time that they were in therapeutic range or not. So the primary efficacy endpoint is actually, it's much better than it was for the intent to treat analysis. And then similarly, when you look at the primary safety endpoint, there's a huge drop here from 7.4 to 1.5, right? But in the control group, it stays similar from 4.4 to 4.4. So suddenly, when they only looked at the per protocol analysis, everything is hunky-dory. But here, this seems to be a far bigger safety concern when they looked at only the intervention group, intent to treat analysis. So if you look at the adverse effects, so this is from the rates from the overall kind of intent to treat analysis. So you can see that a lot of patients had serious pericardial effusions and major bleeding, right? And then if you go back to this flow chart, you can see that the device was attempted to be implanted in about 449 patients, but then a lot of patients had adverse effects, and therefore only 408 actually received the implantation. So this is a good example of why you should do both an intent to treat and a per protocol analysis, because if you were to only look at the intent to treat, then you would conclude that the intervention is actually far riskier than the control group. But then here you can say that these are patients that actually underwent successful implantation, and among them, there didn't seem to be much of a safety concern. So it seems like all the, yeah.
If you could go back to the table. So when they're reporting the differences between the two groups, there is no p-value. So how do you know if the difference is significant? Because if you just look at the confidence intervals, they overlap.
So which values are you talking about?
Like when you look at the observed rate in the intervention versus control group.
Right. So you want to look at the rate ratio. So that's a relative risk. So for the primary safety concern, you see that the relative risk is 1.69, and the confidence interval is 1.01 to 3.19. So none of this crosses 1.
Mm-hmm.
So for the safety concern, you're not looking at non-inferiority. Does that make sense? Your point of reference would be 1 because you're looking at a relative risk.
Okay.
Okay. Okay. So then they also looked at the primary efficacy results by subgroup. And I would really love it if somebody were able to share their thoughts about this. So we can just start off with a subgroup analysis by sex. So here you have 1, which is your relative risk of 1. Left to less than 1 would favor intervention, greater than 1 would favor control. And then here you have the big non-inferiority margin of 2, right? So like we talked about with the previous forest plot, what is the plot for females and males? What is the conclusion? Like, what can you say in terms of non-inferiority among females and males?
So Matt Card, do you want to take a stab at it?
Sorry, could you repeat the question?
So looking at the subgroup analysis by sex, what can you tell about the results among females and males in terms of non-inferiority? So this is your non-inferiority margin is right here. This is 2. So anything less than 2 would be non-inferior, would suggest that the intervention is non-inferior. So you can see here for females, this is the point estimate and these are the confidence intervals. So you can see this is a very wide confidence interval, right? So this crosses it crosses 1. So really you cannot tell if the intervention is superior or inferior to the control. And then when it comes to the non-inferiority, it crosses the non-inferiority margin as well. So all you can say is that it's not non-inferior for females. But then for males, the intervention seems to be both superior and non-inferior. So that's a big discrepancy between males and females. These confidence intervals crossing both line 1 and line 2 basically mean that it's inconclusive. So you can see a lot of inconclusive data from different subgroups, such as, CHADS2 score of 1, kind of like EF of greater than 60%. So there's a lot of variation among the subgroup analysis. That's really what this forest plot is suggesting. Although your final conclusion says that the intervention is non-inferior to the control, you see a lot of variation. So the study concluded that the efficacy of the Watchman device was non-inferior to that of warfarin therapy, and that non-inferiority was not proved for prevention of ischemic strokes. There was also a higher rate of adverse safety events in the intervention group than the control group, but these were mainly related to peri-procedural complications. So the authors are confident that with more training and greater volume load, that the peri-procedural complications could be ameliorated and that these adverse rates would actually go down. But that the safety concerns post-implantation were actually pretty low. So, okay. So any concerns about these conclusions? Now that we've discussed all of it, like what are your takeaways from this study? Are you concerned about anything, about the results, about the conclusions?
We could think about the things that we talked about from the beginning.
Yeah, it's basically a summary of all the concerns we've already discussed.
So just like for the non-inferiority, I would just be skeptical because the margin was too high. So,
absolutely. Yeah. What else?
Also, like one of your main aims when you treat AFib is to prevent ischemic stroke. Exactly. And that one was not non-inferior.
Exactly.
That's kind of like a big deal. So it kind of like the other outcomes don't matter as much anyway.
Yeah. Anything else?
What about the patient population, right? We talked about that a little bit with the difference in the groups.
It seemed like the control group was a little bit sicker than the intervention group. So that is also, setting up for an easier non-inferiority trial in a way. So like you guys said, the twofold non-inferiority margin is definitely a concern, especially when you are unable to prove non-inferiority for ischemic stroke, which is prevention of ischemic stroke is really the key point of all of this. And so if you're not able to prove a non-inferiority for that, it's with a twofold non-inferiority margin, it's definitely concerning. The low rates of therapeutic INR in the warfarin group is also a little bit concerning because what are you comparing against, right? So if you want something really robust to compare against, but like Frida mentioned earlier, this is probably like a good realistic comparison as well of what happens in the real world. And then there's some crossover in terms of the treatment arms, right? So 14% patients stayed on warfarin for at least 6 months after the Watchman implantation. But again, this is something that could happen in the real world. And then there are some concerns about the subgroup analyses as well. Okay. So the main takeaways from this would be, one, a lack of superiority is not the same as non-inferiority. I hope I have driven home that point, but yes, lack of superiority does not show non-inferiority. Always check how the non-inferiority margin is defined and if it makes sense clinically. How much risk is too much risk in real practice? Are you acceptable with saying that something that has an adverse effect of up to 2 times that of standard practice is acceptable to you? You have to think about it. And then you also have to think about the fact that, do these results make sense clinically? For instance, in this example, we looked at, the overall endpoint was non-inferior, but then if your prevention of ischemic stroke is non-inferior, does it make sense clinically at all? So you always have to keep this in mind when looking at a non-inferiority trial. Don't just take the results on face value. These are some fantastic resources that I use to create my slides. A couple of really cool YouTube videos, and I'll take any questions if there are.
Thank you so much, Niru. If anyone has any questions, feel free to unmute yourselves or put it in the chat.
I guess the other thing to mention is just that, it was funded by the company. So I guess that's the other thing. And so it makes you question also why, or it makes you answer maybe that's why some of the things were done. And then I included the article from JAMA, just kind of giving a little bit of examples. I like it because it gives examples exactly how Niru did very beautifully with the cars as well, who's risk adverse or not. It's a nice article just because it gives different scenarios with the graphs as well to really just kind of really hone down like why we do non-inferiority. And the main thing is that's the beginning that you mentioned is like, why would you do these things? And sometimes it just has to do with cost, ease of use of whatever you're studying, and the need for that maybe there's only been one antibiotic this whole time. And so maybe it's the need of something different that may not be any worse than what you're already using. So I think you did a great job as always, Niru. Yeah. You'll be graduating in less than 2 months. This is when so it's already April 21st. You have less than 2 months. so thank you for all that you have done, really, for the EBM as well. But Raf, go ahead.
I just have a question if you have time.
This is the nostalgia, but Nora, go ahead. Nora wants to.
Yeah. So after like submitting such articles, and when the journal review it, so does it usually, but like their like expert opinion about the like results before, because not all patients like read the article as you did, right? So they would say, oh, this is really fantastic, and like we'll take the result on. So yeah. How can we just like make sure that the published article is like taken correctly?
Yeah, that's an excellent point. One of the things to keep in mind also is that, you know, the article didn't explicitly recommend a Watchman implantation, you know, so they just presented results of the study. But then you always want to look at guidelines. So even at this time and age when Watchman implantation is definitely more common and routinely done, it's only I think a class 2 or class 2B recommendation. And it's only used if the patient is unable to take any other form of anticoagulation. If everything else is contraindicated, this is like a Hail Mary sort of situation. So I think always looking at the guidelines is helpful. It's definitely a little bit trickier when it's a medication rather than a procedure or a device. But I'm sure there are always guidelines for all of these things.
Yeah, and this is when you'll see, like I put there, like one example of like where people are commenting on like the study afterwards. And these are the people that are really looking at it like we do in terms of appraisal and really seeing like, are the methods actually correct? And especially the statistical analysis and the patients that are being considered. Yes, you would expect, and this is where we talk about high impact versus not high impact. You expect, especially covered in like New England, JAMA, that they would have people reviewing this very well before something would even get published. But you saw what happened with COVID when information overload and how things were just being turned around so quickly that even some of the journals that you would expect to have some ability to kind of review these things, it was just too quick, and then the answers were needed so quickly, and that happened with a lot of different things. But I think, yeah, in the end, it's up to us, and it's one of the reasons I think even if you're going to research, whatever you're end up doing as a clinician in general, this is something that you need to be able to do. And patients are coming, like patients will read the headlines from a newspaper and be like, hey, what do you think about this? And then you can bring up the article and read it in the way that Niru did so eloquently, in a way that the patient can understand and kind of say, look, like this doesn't seem to be. And then I've had cases like that where the patient's kind of like, oh, it doesn't seem like it's me. And I'm like, yes, that, and they understood like why this wasn't something I was recommending. So I think that's something you have to be aware of, especially with this online world. And then also Twitter and other venues that people are kind of posting things that are not necessarily from online publications like New England, but people are just tweeting and posting things. Any other statements or comments?
Yeah, so I was going to say that that's partially why we have EBM, right? But because at the end of the day, the patient is going to come to the doctor and see, be like, I found this, or like, it's up to us to interpret it and apply it. So that's why these sessions are so important. And just some, I guess, last minute comments just in regarding non-inferiority trials. in general. When Niru was talking about, the non-inferiority margins, like they have to make sense. Like when you define it, like you're gonna give a little bit more room for like non-inferiority if the primary outcome is like ED versus like is it hospitalization or is it like an increase in death, like you're gonna have much less or want to leave much less wiggle room as to how non-inferior you tolerate it to be. And also another thing, and with non-inferiority trials, you rely a lot on the evidence from your control. So you have to make sure, that your control that you're using and comparing your new therapy to actually has really, really good evidence. And not only that, like, is it applicable to your population? So for example, like the therapy that might be compared in the non-inferiority trial, like, was it actually evaluated by a superiority trial that Niru was talking about, or was it like kind of like grandfather from another non-inferiority trial? That sometimes happens. Or I know Dr. O was talking about antibiotics. Like, is the evidence supporting this antibiotics? Like, yes, is it generalizable, like Dr. O said? Like, for example, it might have been tested in a population where this infection didn't have much like ESBL, like resistance, for example, if it's a triaxone. And then your population where you're testing it now, there's like high resistance for it, then you really have to make sure that like when you're comparing those, like comparing it to the control, that it makes sense with your population that you're treating right now, and that it's relevant and current and applicable, like Dr. O said.
Very good, you guys. I think this is the last EBM for the third years, I think, right?
We have one more session. It's the last one presented by residents. We have one more session.
The intern, yes, okay.
Yes.
So I hope that, yeah, that's why I was kind of, so just another, so I was just saying the efficacy versus the adverse events and looking at that. Like, was it efficacious, but also did it cause more harm? Is another way of looking at it, besides is it generalizable to your population, which right away we were like, this group is not very diverse at all. So I don't know how generalizable it is, but okay. So great. I know you guys have been cut on short on time on the other sessions. So I do want to give you time to take a break. So Niru, great job as always. And that's it. So.